I am Joan Weiss, the Deputy Director in the Division of Medicine at the Health Resources and Services Administration, and your moderator for today's webinar. So welcome to the Focus on Aging Federal Partners webinar. The series is sponsored by the Administration for Community Living, the Centers for Disease Control and Prevention, the National Institutes on Aging, and the Health Resources and Services Administration. I would like to extend my thanks to all our partners for their work in bringing this webinar to you today. The topic of our webinar today is workforce needs of older adults. As many of you know, over the past 10 years, the population aged 65 years and older increased from 38.8 million in 2008 to 52.4 million in 2018, an increase of 35%. And this population is projected to grow to 94.7 million in 2060, excuse me. In 2018, 23% of persons aged 65 years and older were members of a racial or ethnic minority population. In 2020, an estimated 5.3 million Americans aged 65 years and older were living with dementia. These statistics bring us to the question, who will care for these individuals? Currently, there are well-documented weaknesses in the healthcare workforce, as well as in the dementia care workforce. And these include, there is an inadequate supply of specialists in geriatrics and dementia care who can provide the expert care needed for treating patients and training the next generation of practitioners. There is limited availability of training for general health care professionals in the best practices of geriatrics, dementia care, and chronic disease management. There are insufficient investments in primary care and long-term services and supports. And there is a shortage of well-trained direct care workers and caregivers. This brings us to today's webinar on workforce development, which will offer insights and strategies to help meet the unique care needs of older adults, including those living with dementia and those in diverse and underserved populations. Next slide, please. Today we will hear from Dr. James Pacala from the University of Michigan, Dr. Joseph Agler from the University of Michigan, Dr. Sanjay Arora from the University of New Mexico, and Dr. Blythe Winchester from the Cherokee Indian Health Center.
Thank you, Joan, so much for that introduction. My name is Jim Pacala, and I'm going to lead off this presentation. Along with my colleague, Joe Agler, we're going to be talking about public health and medical dementia workforce strategies and challenges. I would like to thank the ACL, the CDC, HRSA, and the NIA for this opportunity to present today. And I would also like to thank Joan Weiss, who many of you probably know has done more than just about anybody I can think of to promote the health of the older adults in this country. Next slide, please. As I said, I'm going to start off, we're going to back it up just one, please. One more. There we go. As I said before, I'm going to deliver a few comments really about medical and healthcare workforce challenges, and then Joe's going to talk about it from the public health sector and from the informal caregiving sector. What I'm going to be doing is describing some of the activities that we're engaging in as one of the sites of the Geriatrics Workforce Enhancement Program, or GWEP program, that has been funded by HRSA. It is now in the second round of funding. It's been around for 5 years. We are in the second year of a 5-year award bestowed upon us by HRSA, and our GWEP is known as the Minnesota North Star GWEP. So thank you for the funding from HRSA. Coming from the University of Minnesota, I also would like to express a land acknowledgement that actually Joe is going to describe in detail at the beginning of his presentation. Next slide, please. So when thinking about how to, we're going to back up just one, please. There we go. When thinking about how to address the healthcare and medical workforce needs for dementia care, in the HRSA GWEP program, the current funding cycle has a large emphasis on primary care sites. And so one could think about that we have to engage ourselves in shaping attitudes, in providing knowledge about dementia care, and then provide some resources for how to detect dementia, and then what to do once you have detected dementia from a medical standpoint. What I'm going to be doing is providing just an example or two under each of these headings about what we're doing in the Minnesota North Star GWEP. Next slide, please. So the first is related to, nope, we're going to back up one. There we go. The first is related to just attitudes. And one of the activities that we engaged with in the North Star GWEP this year in conjunction with St. Louis University GWEP program was known as the Interprofessional Case Competition. This was headed at Minnesota by my colleague Jean Wyman in the School of Nursing. But what this does is it brings together a team of learners in various health professions, and we give these young learners with a coach a juicy case of a complex older adult. And what we did is we worked with St. Louis University to come up with a very complex case of a man dealing with dementia who also comes down with COVID-19. And then it's up to these learners to go out and analyze the case from a number of different angles and to come up with recommendations about how they would manage that case. At the University of Minnesota, on a completely socially distanced and Zoom format, we had 116 interprofessional students at the University of Minnesota engaging in this competition. They had likely a similar number at St. Louis University, and then we took the highest scorers from each school, and we had a little World Series, if you will, this winter, where we had the winner of the University of Minnesota competition and the winner of the St. Louis competition square off against each other. And I'm proud to say both teams were excellent, but our Minnesota team came out on top. And this is a picture of our Minnesota team presenting during the World Series. Next slide, please. Another activity that we're using at the GWEP to improve attitudes is Dementia Friends. And many of you probably are aware of the Dementia Friends program, but this is an experience that you take people through to perhaps realign their attitudes and approach in thinking about dementia and in dealing with people and families who are having to live with dementia in their lives. And what we've done is taken a couple of enterprising medical students who are very interested in geriatrics, and working with some of our faculty, they have gone out and spread the Dementia Friends experience to their learner colleagues in different health schools at the University of Minnesota. We've been measuring their attitudes, and there's definitely an improvement in attitudes post session. As you can see here, And we will be continuing to measure attitudes among the learners and the people that we touch in the North Star GWEP throughout the course of the grant cycle. Next slide, please. So that takes care of attitudes. What about knowledge? Well, we're engaging in a whole slew of activities to provide educational and training resources for health professions. One of them that I'd like to highlight is called the Age-Friendly Care and Education Collection. And this is being done through a format, an infrastructure being set up that has been set up at the National Center for Interprofessional Practice and Education at the University of Minnesota. This is a curated collection of webinars, videos, lectures, modules, case reports, and so forth that you can access for free. And I've listed our website at the bottom, and you can easily get through to that if you click on that website and go to resources. It'll take you to the age-friendly collection. It's free and open to the public. But this is the age-friendly collection that we've got. And if you click on dementia, that you can see the keywords on the left. Currently, the collection will bring up 168 curated references relating to the topic of dementia. Next slide, please. And then finally, talking about detection and action. And what we have found in looking at trying to transform primary care sites around the University of Minnesota and around the state of Minnesota into age-friendly health systems is that among our providers will tell us that detection is not the problem. The big challenge for them in primary care settings is what do you do after you've detected cognitive impairment. So this is the mini cog that is used frequently in annual wellness visits to detect dementia, and that our practitioners we've found know how to use and know what to do to detect cognition. So instead, we're going to be focusing more in our interventions on action. Next slide, please. And so action consists of several different things, but mostly of partnerships. And what we've done is we've partnered with the Board of Aging, who has set up the senior linkage line to provide us with links that we can provide to patients dealing with dementia that provide resources. Those two cards on the right are from the senior linkage line, and if you are from Somalia, you can read one of them, and if you are from Southeast Asia and are of the Hmong ethnic group, you can recognize the other. So these cards have been translated into a number of languages that spoken by people that are common in the state of Minnesota. We've also partnered with the M4A, which is the Association of Area Agencies on Aging in Minnesota. There are 7 AAAs in Minnesota, 6 regional, and 1 with the Band of Chippewa. And we linked up with them to help our clinicians link their patients with supports for dementia and dementia caregiving. And then finally, our clinical partners at mHealth Fairview. In primary care, this encompasses about 45 clinics, primary care clinics, distributed across central and north Minnesota, encompassing the care of about 90,000 seniors in the state of Minnesota. We're working with them to connect our primary care workforce with specialty care and to support our primary care service line in the mHealth Fairview system. So this just gives you a few of the ideas, the kinds of things that we're doing to address medical workforce. And now I'm going to turn it over to my colleague, Joe Agler from the School of Public Health, who will talk about public health.
Well, thanks so much, Jim, Dr. Pacala, Dr. Weiss as well. Really appreciate the opportunity to present to you, this great audience here today, as well as alongside this very esteemed panel of presenters. Again, I'm Joe Agler from the University of Minnesota. Wear several different hats, as you see on this introductory slide. I'm really going to talk I'm going to talk about some of our work first in relation to the Minnesota GWEP in engaging both family members or unpaid caregivers, as well as professional caregivers through some of our activities in that very exciting initiative. And then I'm going to try to tie that with a newer initiative funded by the Centers for Disease Control and Prevention, the Public Health Center of Excellence on Dementia Caregiving. And tying those together really with this theme of engagement and how engagement not only drives, I think, our initiatives, but I would argue is probably a theme across these presentations, across cutting theme, in that in order to enhance, build the workforce, it will require significant engagement on our parts to determine not only needs, but also to identify innovations to, again, provide the best possible optimal care to people living with dementia. Next slide, please. So as Dr. Pacala noted, I'd like to begin with a land acknowledgement. The University of Minnesota Twin Cities is located on traditional, ancestral, and contemporary lands of Indigenous people. I acknowledge with gratitude the land itself and the people. I take to heart and commit through action to learn and honor the traditional cultural Dakota values: courage, wisdom, respect, and generosity. Next slide, please. Also, definitely wanted to acknowledge those who have supported our work and have coordinated with us to accomplish some of the work that I'll just very briefly be talking about here today. Dr. Pacala already talked about the Minnesota Geriatric Workforce Enhancement Program funded by HRSA. Again, we are so grateful for that support and what it's allowed us to do in really engaging the workforce and thinking of new ways to partner to, again, best help people living with dementia as well as their families caring for them. I also wanted to acknowledge BOLD, which was the BOLD Act, which the CDC helped advocate for, was passed into law by Congress. I believe it was 2019, and that funding then manifested itself in the establishment of 3 public health centers of excellence. One on dementia caregiving, which is the one that we direct at the University of Minnesota, and there is also a public health center of excellence on risk reduction, which is led by the Alzheimer's Association. Then another center, a national center, which is housed at New York University, that will focus on early detection. So I wanted to acknowledge that. And then, of course, my endowed chair, and then the Center for Healthy Aging and Innovation at the University of Minnesota. All of these different initiatives, I think, work together to help advance this work. Next slide, please. So I really have 2 goals for you today. And, in sitting back and thinking about this, at first glance, I am a researcher, number one. And then number 2, my research really does focus on Alzheimer's disease and long-term care broadly, but really more specifically dementia care innovation, with an emphasis on identifying, designing, evaluating, and then also disseminating and implementing evidence-based supports, particularly for families who care for people living with dementia. So at first glance, it may seem that I don't necessarily align with the overall topic today, which is workforce enhancement in the dementia context. But, if one sits back and thinks about it, I would argue that if we are to address the workforce challenges in this space that Joan introduced earlier, I would argue that it can't be done without engaging the unpaid or quote unquote informal caregivers of people living with dementia. We know, for example, amongst older adults with health needs, 83% rely on solely unpaid caregivers who are primarily family members. That's where they receive the majority of their help. And from a public health standpoint, there is question, and there's actually concern, that can we as a society continue to rely so much on this very large unpaid, essentially, workforce for people living with dementia? If one actually assigned an economic value to dementia care and assigned an economic value to those families who provide dementia care, it's something like 9 times the revenue of McDonald's in a given year. And in Minnesota itself, just in one state, if you had applied an economic value or a dollar value to the amount of care that families provide to people living with dementia, that value would put those families in a Fortune 500 category as a business. That gives you a sense of the prominence and really the prevalence of care, particularly informal or unpaid care for people living with dementia, how prominent it is. But at the same time, we know that in the upcoming decades, there will not be as many family members available to provide that help to older people in need. So with that in mind, as well as with the ongoing challenges to the paid workforce, how can we identify solutions to offset what I call the upcoming impending family care gap? And I think one way is through robust engagement, some of which I'll talk about here today. Let's go on to the next slide, please. So when I talk about engagement, again, as a researcher, when I started, I would argue becoming a more engaged scholar in the dementia care space, it was really somewhat self-serving, quite frankly. As a researcher, I'm always looking to try to identify people to be involved in my studies. And one of the things I did in 2008 is I held a conference. At the time, we didn't have really strong connections to a local clinic, so all of our research was community-driven. We had to go out into the community to find participants for our various studies. And one of the studies we were doing at the time was a comprehensive psychosocial support evaluation for adult children who care for loved ones with dementia. And so I held this conference at the university thinking that, well, this would be a good way to identify some people who could participate in the study. We'll provide some educational seminars and it will kind of be a one-off thing. So with very little promotion, primarily through word of mouth, we had around 80 or 90 people show up at the door, which kind of shocked me at the time. And one of the things we heard, and I learned about really frankly from the attendees, was you have to keep doing this. We need this. There was a real desire, a thirst for this kind of engagement. So we've decided to continue holding the conference every year since. And really how this conference has grown is it's become a truly community engaged event in that it helps us identify what's going on the ground and in the lives of families as well as professional care providers, primarily direct care workers, in terms of caring for people living with dementia in the community. And now, again, with the support of HRSA, we've incorporated this into the Minnesota Geriatric Workforce Enhancement Program. On top of that, has also been very robust community outreach and engagement, county by county education, where I actually, again, with GWEP support, plan to visit every county in Minnesota, and it's a lot of them, there's 87, it'll take me a while, but to visit each of these counties to provide dementia education and engagement, but also more importantly, to hear from community services, resources, families, what's going on in their lives as it relates to dementia. I can't tell you how valuable this has been as both a researcher, but also I would argue as someone like many of us here who have as our goals and objectives to find the best ways to care for people living with dementia. Because when I hear what's going on the ground, it really helps tailor and refine the type of research we do. Next slide, please. This just shows you the counties I've hit before COVID-19. We've transitioned over to webinar delivery, which actually has been very successful. In April, again, with GWEP support, we did a webinar on COVID-19 and dementia, and we had around 1,700 attendees, which was our largest webinar to date. And, again, we hope to continue doing that. Next slide, please. So I don't have much time, but I wanted to briefly talk about the Public Health Center of Excellence on Dementia Caregiving, or PICO. This is funded by CDC. It will be in effect until 2025. And again, keeping with this theme and engagement, the goal of the PICO is to engage with now public health entities at the state, local, or tribal level to, number one, increase access to topic-specific tools, and two, increase use of topic-specific best practices to help better support dementia caregivers. Next slide, please. This is a busy slide, but the reason why I wanted to show this to you is to show that this is the center rests on top of an incredibly robust national network of organizations, all of which have a great deal of expertise in caregiving and care innovations. We have almost 20 different national organizations that are part of our executive committee. Again, all with the goal and the design and the aim of engaging with state and local public health and tribal offices to identify, number one, what help and assistance do they need in advancing support for people living with dementia, particularly dementia caregivers. And then number two, how can the center, with this large, deep collective expertise, help advance what these public health entities are doing? the reason why we really wanted to make this in a partnership model versus a more traditional hierarchical thing where we as a center will tell you, here's what we think you should be doing, is every state, every locality is at a different place in terms of how they're approaching dementia caregiving, how quote unquote advanced they are in terms of identifying dementia caregiving as a public health challenge. And we as a center want to work with all of these entities to help them better support the people living with dementia and their caregivers in their communities. That at its core is what PICO will be, and that's what we hope to do. Next slide, please. And again, time won't allow me to go through the logic model, but nonetheless, you can kind of get a sense here of really what our goals are, both in the intermediate and then long-term as well. And I believe that was my last slide. Next slide. Again, if any of you are interested in learning more about what we're doing at the university, I guess this is de rigueur at this point. We do have a Twitter account as well as an email. Please connect with us. Thank you.
Thank you, Dr. Pacala and Dr. Agler for this very, very informative presentation. I really appreciated you taking the time to highlight the importance of changing attitudes around aging and dementia and developing culturally competent materials for providers and underserved populations. You highlighted innovative practices around community dementia and dementia outreach, which are so important to moving this agenda forward. And you really highlighted the importance of the role of caregivers in dementia care. And I personally and professionally feel that this is a group that really is shouldering most of the work of providing dementia care, but is not receiving the education and training that will meet those needs. So next, we're going to hear from Dr. Sanjeev Arora, who is the founder and director of Project ECHO, a nonprofit that uses technology, a disease management model, case-based learning, and a web-based database to arm primary care providers with the knowledge needed to treat those with complex health problems that would otherwise need to travel for medical care. Dr. Arora.
Well, thank you, Joan, for this invitation. And of course, thank you for all your service that you have provided over many years to improve the care of the elderly in the United States. And many of us will benefit from your work in the future. Next slide, please. So at ECHO, our mission is to democratize medical knowledge and get best practice care to underserved people all over the world. And our goal is to touch the lives of 1 billion people by 2025. And the ECHO started in actually 2003, but in 2001, I saw a patient in my clinic, and she was a 43-year-old woman, and in the room with her was a 14-year-old boy and a 9-year-old girl, and I asked her, how can I help you? And she said, I have hepatitis C and I'd like treatment. So I said, how long have you had it? And she said, I've had hepatitis C for a full 8 years. So I said, why did you not come earlier? And she said, I'd call your nurse and there was an 8-month wait to see you. That's not unusual. On the average in public hospitals in the United States right now to see a specialist, the wait is 6 months. So she said, there was an 8-month wait to see you, and your nurse said I would have to make 12 trips, driving 200 miles each way because I live so far away. And I'm a single mother, and there's no way I could do that. So I asked her, why did you come today? And she said, I'm having pain here in the right upper side of my abdomen. And I got very worried. I did an ultrasound and found she had a liver cancer in the liver, which was slightly smaller than a tennis ball. We gave her all possible kinds of chemo, but she passed away 6 months later. And I was asking myself, why did she die when there was effective treatment available? I knew how to treat this person. Their testing was available in the town where she lives. But the conclusion I reached was she died because the right knowledge didn't exist at the right place at the right time. So she couldn't get the right care. And now I've realized that 6 billion people in the world don't have the right knowledge at the right place at the right time, and millions die unnecessarily. And of course, one of the greatest shortage areas globally is geriatric care because of the extreme shortage of specialists. Let's go next slide, please. So I developed the ECHO model because there were 28,000 hepatitis C patients in New Mexico and only 1,500 had been treated. So I said, okay, I'm going to develop this model. We'll use technology to leverage scarce resources. In this case, it was a liver specialist, psychiatrist, and a pharmacist. And I went around the state and set up 21 new centers of excellence for treating hepatitis C. The second part of this model is to share best practices. So I gave these 21 primary care clinicians my protocol for treating hepatitis C, and they said, no, we are not willing to give chemotherapy in a rural area with interferon injections and ribavirin, etc. It's too dangerous. So I asked myself, how did you become an expert? And when I did my fellowship in Boston and Massachusetts, I would see a patient present to my professor, see another patient present to my professor, and I did this again and again for a couple of years, and they started calling me gastroenterologist. And I said, aha, I'm going to use this model of iterative guided practice to create new hepatitis C experts so that everybody can have treatment. And we would use a web-based database to monitor outcomes. Next slide, please. This is in 2003, I started the first ECHO clinic where all 21 of these sites would join on this interactive video network, and one by one, they would present patients to each other and to us at the university. And every 2-hour ECHO session would be about 8 cases de-identified, no names were taken, and then a 15-minute lecture. Next slide, please. So it was important not to make an ECHO clinic a 2-hour lecture. It was mostly cases, real cases being discussed. And one of the core ideas of ECHO was all teach, all learn. The experts were there to teach these primary care clinicians, but these primary care clinicians had a lot to teach each other because they knew the social circumstances, the cultural circumstances, the barriers to care, the economic constraints, and many, many other things which typically specialists wouldn't know. Next slide, please. So we started doing research and found that in 12 months of participation in ECHO, each of these 21 primary care clinicians became absolute experts. That is, the scale here is 1 to 7, where 1 is I know very little, and 7, I'm an expert who can teach others, and you can see their self-efficacy went from 2.8 to 5.5 out of 7. Next slide, please. And we published in the New England Journal of Medicine a head-to-head study in where we compared the outcomes of these 21 rural primary care sites and prison sites for giving chemotherapy-like regimen for hepatitis C for a year versus the university. And next slide, please. And we were able to show that rural primary care clinicians and prison doctors could give the same level of care with chemotherapy and get exactly the same cure rates as we were getting at the university. And they were able to improve access to care for minorities significantly. Next slide, please. So of course, now that it worked for hepatitis C, we said it could work for a lot of different things. So we started setting up ECHO projects in all these different areas, and antimicrobial stewardship, autism, behavioral health, bone health, cancer, cardiology, and endocrinology, diabetes, geriatrics became a very important subject to start because of the shortage of geriatricians in this country, but also we did infectious diseases and high-risk pregnancy and palliative care and pediatrics and rheumatology and so on and so forth. Currently, we have 70 different types of ECHO projects going on in the world. Next slide, please. So when choosing a subject, we said, use the Pareto's principle. Take the most common complex problems in your community, and I can think of nothing more complex than geriatrics care, and cut horizontally to produce the same level of care at a community health center as you do at the university. And you don't have to do 200 echoes, just do the top 20 in your community and you will have huge impact. Next slide, please. And the goal of ECHO became force multiplication. That is exactly what we think we need for a geriatric workforce. If nurse practitioners and specialists could provide the same level of primary care doctors could provide the same level of care as geriatricians, then we would have what we call force multiplication, which we have defined in health as an exponential improvement in capacity to deliver best practice care. Next slide, please. So this is we wanted to get to 1 billion people. So we said, how do we do that? Since only 2 million people live in New Mexico, we said we would train every university in the United States and any non-for-profit in this country who wanted to amplify their impact. We wanted to train them on Echo, and we would give them our technology platform for free and give them 3 days of training. So one of the first we trained was Beth Israel Deaconess in Boston at Harvard. This is a study they published in JAMDA, 2-to-1 matched cohort study for care in nursing homes. 11 nursing homes received Echo intervention, 22 controls, and they were able to show residents in Echo-age facilities were less likely to be physically restrained or be prescribed antipsychotics. Next slide, please. And then University of Rochester did a geriatric mental health Echo. 500 clinicians were trained, and they were showed they could reduce ED visits and overall costs. And of course, Harvard published another study showing that doing Echo for nursing homes could significantly reduce bounce backs and improve transitions in care. Next slide, please. This is the Veterans Administration that adopted Echo for the 150 hospitals, and they have 600 rural clinics. And so here they showed, published in the leading liver disease journal in the world, that this is for cirrhosis of the liver Echo, that if the primary care doctor was participating, the risk of death from cirrhosis was half than if the doctor did not participate. Next slide, please. And on the next slide, again, a paper from the VA. All you need to look at is for 6,400 patients versus 32,000 patients, they were able to show that 21% of the people whose doctors participated got hepatitis C treatment versus 2.5% only got treatment if your doctor didn't participate in Echo. Next slide, please. And this is US Department of Defense Echo 99 clinics versus 1,283 clinics, showing that for opioid use disorder and chronic pain, there was significant p-value 0.004 difference in improvement in the 99 clinics that participated in Echo and opioid prescriptions. Next slide. We have 300 peer-reviewed publications from our partners around the world now, showing that participation, 214 satisfaction improves declarative knowledge, competence by reviewing electronic medical records. You can see improvement in outcomes in the prescription patterns of doctors as the Department of Defense and VA showed, and then 33 showing patient health outcomes improve. Next slide, please. We currently have more than 250 hubs in the United States that do Echo. Every major university practically has an Echo project. Not all, but I would say 95% of them. Starting from University of Washington, which was #1, University of Chicago, then Beth Israel Deaconess, now Mass General, Brigham and Women's, Johns Hopkins, Yale, MD Anderson, Texas, and many, practically all the major universities, including the University of Minnesota, where Jim practices. These are Echo hubs. Next slide, please. And worldwide now, actually the latest data is we have 450 hubs operating out of 50 countries and learners in 165 countries. Next slide, please. 70% of the land area in the United States has an Echo participant, a learner located both in rural and urban counties. Next slide. So this is the growth of Echo globally. In 2019, there were 237,000 learners. In 2020, the number is 1.288 million. Next slide. So what really makes Echo work is team-based care. Task shift. I am absolutely confident, without 1% doubt, that if the Echo model is used to improve geriatric care in the United States, it will transform geriatric care if it's used widely. And the reason it works is team-based care. Task shifting is the idea of every human being working at the highest level of his human potential. That's what we need primary care people to do for geriatrics, for community health workers to do the same, for nurse practitioners, for PAs. We have found over the last 17 years that 3 things are required for good task shifting: interprofessional consultation, many experts helping you, guided practice, and mentor-mentee relationship. Echo is also a community of practice. It's a social network. It produces joy of work. And this is the primary reason it works, because of relationships. I always like to say what makes ECHO work is love, respect, kindness, empathy, and community building, not just the knowledge of expertise. Technology reduces the cost of collaboration. Force multiplication is exponential capacity building. And we have to demonopolize the knowledge of every geriatric specialist, and all teach, all learn means experts have to learn. And we need to make a movement regarding democratization of expert knowledge, which is the goal of ECHO. Next slide, please. So around October of last year, AHRQ approached us, which is a federal agency, the sister agency of NIH and CDC, etc., and asked us to launch a project for National Nursing Home COVID-19. What was the problem? At that time, even though less than 1% of the population in the United States lives in nursing homes, 40% of all deaths had occurred in nursing homes with COVID-19. Next slide, please. So we launched an ECHO model. You know all about that. We already had a large national network doing other kinds of diseases and already doing COVID-19. We also partnered with the Institute for Healthcare Improvement. Next slide, please. So the core element, of course, were the same in this nursing home ECHO: all teach, all learn. Key role of, they were facilitators at the universities, and then we put these nursing homes in cohorts of 33. So one network would have 33 nursing homes. There would be domain experts and a quality improvement coach at the academic center at the university, and they would run these weekly sessions training these nursing homes on how to manage the COVID crisis and prevent deaths in nursing homes. Next slide, please. So the goals of it was to prevent COVID-19 from entering nursing homes via staff, visitors, patients, preventing spread within the nursing home, providing best practice care to treatment who test positive for COVID-19, and then protecting staff from infection. And next slide, please. So we have launched 251 such networks so far in the United States. So 281 weekly cohorts of ECHO sessions going on every week right now. Next slide, please. And actually, the number of nursing homes enrolled is 8,500 as of yesterday. And you can see in these deep green states, more than 75% of all nursing homes are participating, and then less. And we also partnered with quality improvement organizations, AMDA, American Medical Directors, ACA, Leading Age, and also created an advisory board. Next slide, please. And we enrolled 99 academic type of centers or QIOs, mostly academic centers. Goal was to enroll all 15,000, but not all nursing homes are interested. So, and we incentivize participation of nursing homes by giving them $6,000 a piece. We also did these large scale webinars in less than 4 months now. We've got 8,400 actually participating nursing homes. Next slide, please. In terms of the curriculum, we were covering preventing and spread of nursing homes, approaches to cohorting, promoting solutions, COVID testing, antibody treatments, effective leadership and communication strategies within nursing homes, managing social isolation, role of CNAs, all kinds of different curriculum topics were covered. Just to give you an example of some results, in fact, the best way to show results is a story. I got an email 3 days ago from a nursing home in Nebraska. This is what it said. This is one of our 8,500 nursing homes. They said, look, you taught us to give antibody treatment to elderly people when they got COVID-19 in ECHO. And it so happened after you taught us, 30 patients in our nursing home got COVID-19. And of the 30, we gave them all the antibody, and then 28 survived. 2 of them who survived were over 100 years of age. So we were able to rapidly deploy some of these best practices in nursing homes. Next slide, please. Then there was also, in parallel to this domain curriculum, there was a quality improvement curriculum taught by quality improvement experts. So every cohort had a QI expert joining every session. And there they talked about honoring the work, conversations to prepare for improvement, psychological safety, taught simple models of improvement, high-level flow diagrams, listening to residents and families, and the role of leaders in improvement, etc. Next slide, please. Additional topics we had to cover because it was constantly evolving was vaccine resources, vaccine education, vaccine hesitancy, distribution, logistics, staff mental health, because a lot of burnout was in dementia care. Next slide. So the way we designed this session was there would be 16 sessions for each nursing home in phase 1, and now we are planning the phase 2. There will be another 36 weeks. And we had 7 streams of data coming back to us. We had feedback data coming from nursing homes, so we could constantly change what we were teaching them. We had data coming from the experts. We had data coming from our QI experts, our facilitators from AMDA, etc., and our external advisory group. And we were making changes. Next slide, please. And really, this summarized what ECHO is. This is Godfather 1. This is Marlon Brando, Francis Ford Coppola. And the question is, how do you make a great movie? And next slide. And the answer was get everyone to make the same movie. And thank you for your attention. And thank you for this opportunity to Joan to speak to your audience.
Dr. Arora, thank you so very much for this wonderful presentation, but especially thank you for reflecting upon the care you provided to the woman who had hepatitis. And by you doing that, you were able to build this incredible model, this team-based model to provide care to individuals in rural and underserved areas, in nursing homes, into the populations that are the most underserved of the underserved. This is a new way to address shortages, not only shortages of healthcare providers, but shortages in underserved areas. And we are just so grateful for the work that you have done in this area. I would say most, probably about 75% of our geriatrics workforce grant recipients use your model. So we have drank the Kool-Aid and are really pleased with its results. So thank you for this work.
Thank you.
Next, we will hear from Dr. Blythe Winchester, who is a board-certified geriatrician and member of the Eastern Band of Cherokee Indians in Cherokee, North Carolina. She practiced at Cherokee Indian Hospital and is the certified medical director of the Solid Care Center. She received her medical degree and her Master's of Public Health at UNC Chapel Hill and did family medicine residency in Greenville, South Carolina. Dr. Winchester, thank you very much.
Thank you so much, Shio Nagata, Blythe Winchester, Dagwadoa. Hello, everyone. My name is Blythe Winchester. I want to give a huge shout out to Lisa McGuire, who extended an invite to me to get me involved with all these Jerry famous, awesome people on this talk today. So thanks so much, Lisa. Next slide, please. I put these into every single talk that I give. They're the Cherokee core values. And the reason I include them is because they're the most important thing about me and what I try to incorporate into every single action that I do on a regular basis. Next slide, please. So I'm a full-time practicing clinician. So when we think about what do these neurocognitive disorders do, a lot of it for my world has to do with what it causes, changes with for the patients and the families who are encountering it. So a lot of when we're talking about workforce development and what kind of skills are needed, it's helpful to look at kind of the problems and the changes that take place for those who are affected by these disorders. And the list that you see there is not all encompassing. There are obviously many more behavioral and psychological symptoms associated with dementia that can cause other issues, things like wandering or even combative behavior. But I think it's important just to have a reminder of exactly what we're dealing with here, in addition to the shortages in service provision that have already been detailed. Next slide, please. So this was already mentioned by Joan, and it's very important. Workforce needs, especially when it relates to dementia care, this is a huge area of that needs improvement, right? And she had already mentioned some of the issues with the current gap, the future demand. One thing I want to emphasize that's a little bit different in my world in service to Indian country is those special considerations. So on top of everything else that we're worried about in our workforce, we're thinking about, wow, we are such a heterogeneous group of amazing tribal communities, and we all have different considerations and different needs, things that relate to language, things that relate to our traditions, our family structures. So it makes it even more difficult when you're trying to address those workforce needs, particularly in our more rural tribal areas. Next slide, please. So in terms of current challenges, and some of this has been mentioned, already, we have a lot of issues in terms of payment, the options for types of caregiving, training, and education, a lack of data, particularly in our American Indian and Alaska Native communities. There isn't a ton of information about what our workforce is experiencing, what the challenges are, how do we improve that. It's like much of the things that are involved in Indian country, the lack of data is an issue with that, right? The demand for healthcare providers in general is increasing. That's been mentioned several times, that we don't have enough specialists in geriatrics and dementia care to serve the population of this country, much less our tribal populations. I'm one of a handful of geriatricians that serve Indian country, and I'm one of just a couple of indigenous geriatricians who serve those communities. Next slide, please. We have a significant underappreciation of the workforce, what they do, the priorities involved, having people understand what the needs are and that these are very real, and then a shortage of well-trained direct care workers. All of this, is well documented, and I'll bring up some others in a few minutes that are kind of uniquely related to our tribal communities and those considerations. Next slide, please. As a reminder, I get really excited because when I used to talk about these sorts of things several years ago, we didn't have any data, and I would just be, talking to people, and I would say, I swear, this is a huge deal. We really need to be talking about, dementia in our community. So I get excited when I can talk about data now. And this is just an example of a Kaiser study that showed that the incidence of dementia among self-identified American Indians and Alaska Natives was second only to incidence among African Americans. It's part of what has helped us in driving policy and funding and all those things that we need, is saying, look, we know this does exist and we need help, in our resources in this area. Next slide, please. This is just another example that shows, age-adjusted Alzheimer's disease death rates in American Indians and Alaska Natives. You can see the adjusted and the unadjusted. We are running in much the same of a kind of graph pattern, as the U.S. all races, and it's important to acknowledge that. Next slide, please. This next one just shows that we have documentation in every area across Indian Health Service that the dementia diagnoses is something that's being documented. So I know this is a little bit difficult to see just in terms of distribution, but for a very long time, providers, nurses, other people have been documenting these diagnoses in our electronic health records or otherwise. Next slide, please. As a reminder of demographics, in case you aren't very familiar with, our populations in general, the American Indian Alaska Native population is growing rapidly, not just in the elder population, but it's really exciting to me that the oldest cohort of adults, those who are 85 and older, that group is projected to increase more than sevenfold by 2050. So as you can imagine, as a geriatrician, that's both exciting and terrifying if you're not prepared across your system to handle those different geriatric syndromes and issues that may arise. Next slide, please. This is just a scope. Again, I get excited about data like I mentioned. Between 2014 and 2060, the number of American Indian and Alaska Natives aged 65 and older living with dementia is projected to grow over 5 times. In the period of time 2015 to 2017, 1 in 6 aged 45 and older reported subjective cognitive decline. So self-reported difficulties in memory or thinking. And nearly 2/3 of those with subjective cognitive decline had to give up some kind of day-to-day activities because of these cognitive problems. So it gives you an idea of the day-to-day struggles that are taking place. And it was mentioned earlier that, detection is not so much of an issue as it is what you do once you diagnose that. And unfortunately, in Indian country, we are still struggling with that detection piece. Next slide, please. So my knowledge about workforce needs, obviously because I'm a practicing clinician, has a lot to do about those clinical needs related to dementia care. And this is where, thus far in Indian country, we've focused a lot of our efforts. Education has been the #1 area of focus that we have addressed, thus far. Other things listed here are pretty standard. What I'll mention is, in addition to those special considerations listed, in our communities, we think about the histories that have happened to our Native people, issues with relocation, trauma, boarding school, and all of that also affects dementia care and what is needed. Next slide, please. This next few slides it lists examples of things that we've been doing within IHS and our tribal communities to try to provide the education that people have asked for and crave when it comes to dementia in Indian country. So the first one listed here is the roadmap for Indian country. If you have not looked at that, it's available online, and it's a really excellent resource for tribal communities when looking at dementia care and strategies that can be used. You can read through that list of a lot of different pieces of education or talks or webinar series that have been provided in our tribal areas to try to help to improve the education. One thing that's listed on there that says current is integrating dementia education across different disciplines. And you can see that in some of these educational events that are listed. One thing that Indian country does well is that we say dementia is not a standalone problem. Dementia is related to diabetes. It's related to heart disease. It is related to respiratory problems. It is integrated into all of these other problems and should be addressed in those different issues. So you'll see these kind of pop up in different things where you think, oh gosh, diabetes in the brain. Yes, that was presented, at the Indian Health Service Diabetes Conference. It was presented on elder care at an Indigenous Women's Health Conference. So we do a good job of integrating that. Next slide, please. This is more examples, and it just kind of highlights that there is a real variety of different types of education that's been provided. Everything from, cross-cultural considerations to looking at research in dementia and Native American populations and what do we need to consider there, what are the barriers, tools for providers themselves, tools for patients, tools for different communities. So we just try to get a really well-rounded approach to this. The age-friendly commitment to excellence, I'll mention just a little bit more about. And becoming a certified dementia practitioner is an area where some tribal communities have been able to really enhance their work in dementia care. Next slide, please. So I mentioned the age-friendly health systems movement. If you're not familiar with this, the website is at the bottom. My hospital system recently became the first tribal system to be recognized as having a commitment to excellence and being age-friendly. And that includes our tribal skilled nursing facility in our outpatient area. The basis of this is to use a 4Ms model of geriatrics care to improve care for elders across different, spectrums in healthcare. One of the M's is mentation. So it's a really excellent opportunity for different tribal areas to see what they can do to enhance, their dementia care, their assessment, and all those types of things. So part of what I'm working on is trying to get more tribal communities engaged in this age-friendly work. Next slide, please. This is just information that was actually from a study about diabetes, but it just goes to show that when you're looking at the challenges and quality of life for caregivers, we can't forget that. We can't neglect it. And some of what we've emphasized is programs to try to help caregivers with education, and part of this also relates to the workforce. It was mentioned before, the use of standardized tools and assessment, and I just want to mention that that's been quite difficult for us because sometimes we're not sure that the assessments that are in existence are the best ones for our tribal communities. But we also have trouble waiting on the pace of validation of instruments to be able to implement something new that might be better. So it is kind of an ongoing, challenge as it relates to this. I'll also mention that for tribal communities specifically, there can be different cultural considerations when you're looking at caregivers, because sometimes, our caregiver structure may be different, may be more complex, may involve a lot more caregivers. And something I encounter quite a bit is how do you honor the matriarch in the household while also, reminding her that it's time to take a shower and to do those types of day-to-day things. So there are some different considerations, that we want to include in those different things to improve our workforce. Next slide, please. These next couple of slides are directly from the roadmap for Indian country, and I put them in here because I feel like it's one of my favorite parts of the roadmap, and because I think that in our communities, another thing that we have to think about and consider is a lot of times we have competing priorities. For example, in my community, a lot of times so much work is done on substance abuse and mental health that sometimes we're trying so hard to get what we need when it comes to dementia or elder care. And I think these strategies do a good job of reminding people why that community action and community members are so important in moving workforce development and education in our tribal communities. This one just mentions, making sure you're working with community members to understand all the things that relate to dementia and encouraging them to use those best practices and traditional wellness practices. Next slide, please. Providing information and tools. I've mentioned before, tools are another thing because we're so heterogeneous. We like to have kind of a bit of a template or a program, but then we like to have some flexibility in it so that we can adapt it to our community. Or if it's a program that's not been used in Indigenous communities, then we want to be able to indigenize it to make it more appropriate for use in our areas. Also promoting engagement among tribal leaders. A lot of times our leadership structure in our sovereign nations involves council members, it involves chiefs or vice chiefs who lead a lot of the work in prioritization of healthcare needs and other things like that in our community. So it's important for us to remember to incorporate them into the things that we're trying to do. Next slide, please. So some other things I'll just mention real quickly that have been done or are currently being done, trying to develop dementia-friendly communities for different tribes, having dementia care specialists. The Banner Alzheimer's Institute has their Native American outreach program. We have the eye care program. We have people developing materials for Indigenous community-based care. We have the work with IA Squared and trying to develop, culturally appropriate materials, their Healthy Heart, Healthy Brain program. So there's a lot of different opportunities. I will say, as I'm ending here, that I'm really excited because we have found out that part of the budget for Indian Health Service this year allocates funding specifically for dementia. And this is the first time that this has ever happened in history. So, that makes me really excited. Ideally, my dream would be to have something like an ECHO. I did the immersion course in 2017. I'm a true believer But this budget will have to determine, what the needs are and how to meet what those requirements are, and we'll obviously have, tribally based input. So I can't say now what will happen, with the budgetary money, but I'm just excited that it's there and that it's been allocated now and that it is for dementia care. Next slide, please. So I really appreciate your time. I have my email listed here. So if you have anything specific, questions that I haven't addressed, then please reach out to me. And thank you to everyone who's put so much work into this, and, allowed me to share a little bit of what I do. And thanks to all the other panelists. It's really an honor to be on here with you. I've seen talks from you many times in other places. So thanks again.
Dr. Winchester, thank you very much for this very informative presentation on workforce challenges in Indian country, as well as educational challenges and caregiver challenges, how you adopted the age-friendly principles into your health system, which just speaks to the versatility of the age-friendly framework. Started in public health and then in hospitals. We picked it up to integrate into primary care. You're picking it up into your hospital system. So this is really another wonderful movement. And thank you, all of the presenters, for really speaking to the importance of community. It is through community that we can address workforce issues throughout the educational continuum with patients, families, caregivers, direct care workers, health professions, students, residents, fellows, faculty, and our practitioners. So thank you all, and we will open it up for questions. Oh, just as a friendly reminder, please stay tuned for updates for our next Focus on Aging Federal Partners webinar. It will be in the spring of 2021, and the topic is disclosure of research and clinical findings related to cognition. Thank you. Next slide. So we will take questions now, and I have some let's start off with this question for Dr. Agler. Are there specific resources to provide to caregivers?
This is right up your alley, Joan. I know it is. Let's start with the HRSA dementia curriculum. So I am happy to, yeah, I knew, right up your alley. So we can, there are a number of wonderful resources out there. I think in some respects, I would argue there are so many resources that it's overwhelming. So I will share with you what I think are some of the best for again, families and others who are on this journey of caring for someone living with dementia. I will start with the HRSA dementia curriculum. And Elizabeth or others who are on, if there's an opportunity or a way to share this to the attendees, that would be great. So the HRSA dementia curriculum, it includes two components that really highlight key topics related to, number one, caring for someone living with dementia, and then as well for caregivers of people with dementia, both professional care providers as well as family caregivers. I was very honored, along with the late Dr. Bob Kane, who's endowed chair, whose name bestows my endowed chair, is we worked on these together. It was one of the last things we worked on together. Very community engaged, vibrant process that allowed for multiple perspectives to be incorporated into the curriculum. It's really easy to use. It's an excellent set of resources. You can actually just Google HRSA, HRSA dementia curriculum, and I think it'll be the first thing that comes up. You know, I think for other great resources out there for family caregivers specifically, the two best that I like to refer people to most, really there's three, I think, that I really like referring people to. Certainly it's the Alzheimer's Association. Again, I am biased. I contribute to the Facts and Figures report every year. I actually write the caregiving section. But the Alzheimer's Association has compiled a really great resource center for caregivers, particularly caregivers of people living with dementia, which I think is wonderful. The National Institute of Aging, they're what is called the Alzheimer's Disease Education and Referral Center, or ADIR, is incredible. And all of their resources are free. They have a number of great downloadable resources you can utilize. The last one I really like, and the reason why I like this one is it's a little different perspective, but the Family Care, or is it the Family Caregiver Alliance? Yes, caregiving.org. They have a couple of great resources on their site. One is they have a map. It's they call it the Family Care Navigator. So depending where you live, you can go on this map and click on your state, and it will generate a really great up-to-date resource list of contacts that you could and may want to reach out to, whether it's financial, legal support, it could be support groups, anything, you have home modification, environment. So the list goes on and on. If you are a provider or an organization and you would like to incorporate an evidence-based intervention and deliver that and adopt it for your organization for caregivers. The other thing the Family Caregiver Alliance hosts on their site is called Best Practice Caregiving. Again, you can Google Best Practice Caregiving. It's a great tool because it goes so far beyond the traditional research perspective of, here, you want to learn about evidence-based intervention, let me show you this meta-analysis or HRQ. I mean, that is not accessible for 90% of the population. The Best Practice Caregiving tool is designed specifically for organizations and providers. It gives them the information they need. So if they're thinking of, I would love to adopt this type of intervention, but I can only pay this much and I only can spend this much time in training, this tool allows you to make those decisions effectively. So those would be the ones off the top of my head I would refer. There are many others, and I know I'm missing some, but those were the three usually, right away I like to direct people towards. I mean, quickly, there's the Respite Locator is a good one. The National Adult Day Service Association, they have an Adult Day Service Program locator. So again, a lot of this needs to be tailored to specific needs, but in general, that's where I like to go first.
Thank you so much, Dr. Agler. I believe this next question is for Dr. Winchester. And the question is, what workforce supports are available in terms of traditional healing and cultural ceremonies for people with dementia and family caregivers?
So this isn't something that you're going to find that has any kind of, structured program available anywhere. What you'll find is that tribe to tribe specific, there'll be certain things that they use, and I guess a certain level of how apparent the traditional healing piece is. For example, we have some clinics and areas where there is found to be a good cooperation between having, a medical clinic and then also having a traditional healer in place within the same building. But then you'll also have other tribal communities where that doesn't really work, very well. Like here, we wouldn't have a space where the traditional healer is because those are fairly separate. So it is pretty tribe dependent. They were mentioning, before kind of caregiver resources, and we do have the Savvy Caregiver in Indian Country that was developed by NICOA. And some of their resources do address this question as well. And that's available free, online through the NICOA, National Indian Council on Aging website. So if you wanted to look at that too, that would provide some good resources. Sorry if I don't know if that answers the question, but.
And then we have a question, I think it's for Dr. Aurora. The question is, what part of Mexico is cooperating with the ECHO initiative? I'm not sure if the participant in the meeting meant New Mexico or Mexico, but if you could address both, that would be great.
So yeah, I think in New Mexico, which is in the United States, as you know, we partner with the state health department, with the human services department, with Medicaid agencies. We also partner with our education department. We partner with our Department of Aging in the education department to mentor school teachers. So I think we have massive and extensive programs in New Mexico with about 400 spoke sites, clinics connected. In the country of Mexico, we have also got several projects out of the Autonomous University and mostly out of Mexico City. We also have partnerships with Border TB, with our US CDC and the country of Mexico, and then with multiple not-for-profits in the country of Mexico that do ECHO. I hope that answers that question. Yeah.
Thank you, Dr. Aurora. And for Dr. Pacala, how would you respond to gaps in the dementia care workforce among Latino and non-English speaking population groups?
Thanks for the question. And before I answer, I just wanted to express my appreciation for Dr. Winchester and Dr. Aurora. I learned a lot from your presentations, and so thank you very much for that. I learned from Joe Agler every day, but it was very nice to hear from you. I think the challenge of reaching different cultural groups, Latinx, other cultural groups, is being able to design educational and clinical interventions with cultural representatives of those groups. I think that's for me, that's one of the bigger challenges I have because I tend to apply my own biases to designing resources and to training learners. So I think the best strategy is to make sure that you are inclusive of cultural representatives when you are designing such interventions that tailor the intervention to the paradigm of the target audience. So that's kind of a generic answer, but I think that's the way that we try to approach our work.
And Dr. Pacala, to build upon that, are you aware of any workforce development programs that target the Latino community, specifically the high school student population, to engage them to go into geriatric healthcare studies in college and beyond?
I am not informed enough to be able to answer that question directly. I will say that at the university, well, where I am in Minneapolis, we have several programs, pipeline programs. One is called the Ladder. We actually start at age 9 in a program called the Ladder, where we take kids in school, in primary school, and expose them to healthcare professions. And then we have another program where we target undergraduates at the University of Minnesota of color who might be interested in health professions careers. And we provide them with opportunities to engage in shadowing and in projects and in mentoring with faculty, primarily in primary care and some in geriatrics, but not as much in geriatrics as I would like, put it that way. So that's something that we're going to need to work on.
Wait, hold on. Okay. And the individual who asked the question, I apologize, from Wisconsin. So I know we're a different state, but maybe we could reach out to our colleagues in Wisconsin and see if we can get back to the individual from the Bureau of Health Workforce side. This question probably is for Dr. Gabler. The impact of COVID has impacted the aging population, especially the dementia community. How do you recommend reassuring caregivers that new businesses such as adult daycare health are safe?
I think that's a great question. I mean, that's something I've been thinking about a lot through this entire pandemic. I actually wrote an op-ed for the Minneapolis Star Tribune on this exact topic. And one of the things I think COVID-19 has shown many of us is the fact that community-based long-term services and supports for older persons with health needs, particularly for those living with dementia, is critical. And unfortunately, many state governments made the decision that, well, community-based adult day programs should be shut down or not considered quote unquote essential services. But one thing is if you talk to families who are utilizing adult day services for respite or other types of really necessary therapeutic or other types of support, these programs are more than essential. And that was basically the message that we had included in our op-ed per se. I haven't seen any evidence to suggest that community-based programs are or were or continue to be hotbeds of COVID-19 transmission in comparison to residential long-term care settings. Again, I mean, to me, what COVID-19 has really shown, now whether it actually results in true policy change is another question, but what has really shown to me is the need for true integrated models of care for older people, models that incorporate effectively community-based supports with acute care services or other types of chronic disease services together under one umbrella to help address the needs of older persons, because we know from the research and science that does lead to more positive outcomes. The model I think of most often is a model like PACE, programs of all-inclusive care for the elderly. Now, they haven't been scaled up to the degree that I think they should be, but essentially utilizing something like an adult day program to house care management, acute services, and just an array, an umbrella of needed supports that we know are effective for older persons in need and can help them achieve positive outcomes. And I think what COVID-19 has shown is the need for that. But unfortunate, whether that actually leads to any substantive movement in more advanced models of care is unknown at this time. Certainly what COVID-19 has also shown is we need to figure out more effective ways to pay and support and resource nursing homes. Because, and I don't think that we need to go in depth on that particular topic here, but clearly how we provide support to nursing homes, how we pay for nursing home care, was really exposed in shocking ways during COVID-19 as well. And I do think expanding community-based service supports is a potential answer to that. So.
Thank you, Dr. Gabler. Dr. Aurora, although I think you covered this really well, I'm just going to present this question to you in the event you have anything to add. How can workforce development concerns be addressed when a long-term care facility is in quarantine?
Yeah, no, I mean, I think that one of the challenges that we found, so Jim pointed it out, was that long-term care facilities are chronically challenged and have had quality concerns for a long time, which are a result of their inability to have appropriate staffing, high turnover. Often the staff working in there doesn't have adequate amount of training. And then when COVID-19 came along with that, we actually got completely, it was devastating. As you recall, there was nursing homes where 80% of the residents died. And I think that they were not prepared to institute infection control practices, etc. Now, in the quarantine arena, the advantage of an echo-like model is it doesn't need anyone to travel from any place to anywhere to actually participate, learn, and implement. And we can have collaboration without actual meeting. So I definitely think that in the COVID-19 world, in quarantine, etc., we actually find that, in fact, the productivity of people is going up rather than down, as long as you implement the model with fidelity, because travel time is saved and people can actually do their work. And so I've not found that to be a problem. I have one question for you, Joan, if that's okay. I think that, as I mentioned, we are confident right now, and everybody who's done echo is confident that I know of in the geriatric space, including the Alzheimer's Association, which is a massive echo replicator, that if we deploy this across this nation for nursing home care, for elder care in primary care settings, for training community health worker, geriatric workforce, etc., we can transform the care of elderly in a very cost-effective way. So the question for you, Joan, your CDC partners, HRSA, NIH, all partners is, what should we be doing as a group of geriatric echo clinics, universities, WEPs, to influence policy that we don't have all these elderly people dying in the world, in the United States, without the appropriate care in their homes, in their primary care settings, in nursing homes, in elderly, other kinds of facilities, assisted living facilities, etc. So this question is for you, Joan.
I think the mission of the Public Health Centers of Excellence, and I believe I think I'll be addressing your question here. It's a great question. To me is, when you look at, and again, whether it's residential long-term care, and certainly in the space of community-based long-term services and supports, in many states, you have the aging service network kind of building and focusing on what they do. You have the departments of health, public health entities, focusing and doing what they do, and oftentimes they don't meet, they don't work together. A big goal of the CDC Public Health Center of Excellence, certainly it's going to be a goal of ours, is to figure out ways that the aging service network, whether it's residential long-term care or community-based, and public health offices can come together and find ways where they can work together to advance key initiatives, in the case of our center, to support dementia caregivers. But I think that could be also viewed more broadly as well. Oftentimes, and I think a lot of it has to do with how these units, how they're funded, and really traditionally how they've evolved in states, is that oftentimes, departments of public health don't necessarily look to see aging services or even healthcare systems to some extent, certainly in the case of dementia, as potential partners to work together in terms of messaging, which I think what you're alluding to, in terms of, helping and engaging with communities understand or employers or other entities, why is dementia a real public health concern for the US, for our state, for our communities. And the way to solve it is not to continue working in silos, but to work together to integrate and merge not only service delivery, but also public health principles too. The model of ECHO is a tremendous model, and I can see why it's been so successful and has gained such traction, specifically in reaching out to residential long-term care providers. I would argue that kind of model will be needed as well, in bringing others to the table, in learning about dementia as public health issue of interest and such. So I believe that kind of answers your question, but that's how I would envision and see it. The need to build bridges.
Joan's opinion too. Joan, do you have a last comment in the last minute?
So I agree with Dr. Agler. I agree with everything he said. I think to move the needle with ECHO, we need to address it at the local, state, regional, and national level. And I think, obviously this is a grassroots effort that has really taken hold. So the next thing I would recommend would be to approach the state get the state buy-in. The federal buy-in is already there, but you can always write policy papers to, make your case for why this should be a federal initiative. Within HRSA resides the federal Office of Rural Health Policy. So it's their own office. They just have their offices within our building. They are the telehealth initiative for the government resides within the Federal Office of Rural Health Policy. So that's one place to start at the federal level. You could always reach out, to us. For us, we felt telehealth was important enough to make it a requirement for all of the WEP grantees to do. And that's why most of them are doing ECHO, because that's the most effective way.
Yeah,
so I hope that answers your question.
Sorry, I didn't mean to interrupt, Joan. One thing related to what you just said, Joan, about that, and one thing that's interesting, and I don't know if there's been engagement, Sanjeev, to connect, is there's the Raise Family Caregiving Council, and they've been tasked to develop basically a national family caregiving strategy at the federal level. They've put up a list of multiple recommendations that are going to be delivered shortly. Fine. And Joan, I'd assume HRSA has been involved. I don't know if they have been. But
I'm a federal member on that committee.
That's what I figured. So, that taking Minnesota ECHO and showing, this is what's been done here, is there a corollary in this space would be a potential interest, certainly something that could have potential federal ramifications. So,
and I could have, Dr. Aurora, we can take this offline. I could speak with Greg Link for you to present at the next race meeting.
Thank you.
That would be great.
Look forward to that. Okay.
With that, this is the end of our meeting. We're 2 minutes over. I apologize to the audience and to our speakers. And this was really an outstanding session. Thank you all for taking the time to prepare and to present. We really, really appreciate it. And thank you for all your work in advancing geriatrics workforce development and dementia workforce development.
Wonderful. Thank you for the opportunity.
Thank you.
Bye-bye.
Bye-bye.